Thank you for the introduction, maybe a bit excessive, but the context will be slightly different from the one that the previous speaker has presented to you. We are moving from the post-transplant patients to the hematological ones. I have no conflict of interest with this presentation. I think that we have several problems concerning the approach to these patients, which imply also the allocation of these patients depending upon the resources that are available in the different hospitals. Because unfortunately, all of you well know, at least in my country it is absolutely true, that we do have a bed constraint into the ICUs. And at times we are obliged to find a solution treating these patients not being possible the admission to the ICU, also outside the ICU, but whatever. Imagine of having a patient like this whose picture is classically the one of a patient with a, would say, possibly a mild or a severe ARDS. And now the first moment and the first question that we should ask to ourselves, if I see a patient like this on a consultation in the hematological department, should I move him or her directly to the ICU, or can just to start a treatment within the ICU? Just to respond to this question, I want just to allude to the new definitions of ARDS. A task force in Berlin just had a long discussion on the new definition, and has been published in the Intensive Care Medicine an interesting paper for the applicability of the concept of the different severity of this syndrome. And I think that one of the most valuable proposals made by the task force is just to allocate the different interventions in patients having ARDS depending upon the severity of the syndrome. As you can see, that even though the evidences that we have in our hands to propose the use of non-invasive ventilation in these patients is not so strong, nonetheless, the Commission, the task force, proposed that can be used at least in the early phases of ARDS. So the real problem is that one. If I have this patient, am I obliged to move him into the ICU, or can I treat into the ward? Well, the first concept by using any ventilatory approach, especially if this approach is a non-invasive one, is that the best way to be successful and hoping a good resolution of the picture is applying the technique very early, at the very early stages of the disease. And we do have also some demonstration, both in adults and in the pediatric field, where whatever would be the interfaces that we apply for delivering non-invasive ventilation, this may represent an advantage, having more than 50% of the success also outside the ICU. And the paper coming from the Marco Ranieri group, when he used to work in Turin, showed us in a study that was aimed to demonstrate the capability of non-invasive ventilation to prevent the admission to the ICU, that indeed, as soon as, with respect to the conventional oxygen therapy, they applied non-invasive ventilation to these patients with hematological malignancies in the ward, indeed they were capable to reduce the number of admissions to the ICU. And even though the number of patients that were enrolled in this study were small, nonetheless there was a signal in a reduction of the mortality rate. But there is a problem that I think we have always to keep in mind. As soon as we have the bed constraint, as I alluded to, we have the need of treating these patients outside. But this implies unavoidably that you cannot do that on your own. You need to have an early intervention, and so you need to establish an educational track of the specialists, the oncohematological specialists, for instance, when they can recognize the symptoms and can start to, in collaboration with the intensivists, also outside the ICU. Obviously, if you have the easiness of moving the patient into the ICU, it can be better. But let's have a look on how the pressure support, which is the most classical mode of ventilation works. We know from the French studies that pressure support is very active and very productive modality of ventilation to reduce the work of breathing and to reduce the transdiaphragmatic pressure and the time pressure product as expression of the workload of the respiratory muscle, as well as this kind of mechanical ventilation given non-invasively is capable to improve the oxygenation and the elimination of CO2 efficiently both in physiological and in clinical studies. However, we have a warning, which is very important. When we treat these patients, there is an intrinsic difficulty, because as soon as you interrupt the administration of positive pressure ventilation, you may run a risk of the recruitment. And at the same time, if the patient does have an RDS, one of the things that physiologically these patients in acute respiratory failure do is just having a deep inspiratory swing, and then they can produce an important transpulmonary pressure, which is one of the major determinants of the pulmonary damage. The real problem is that for the moment we don't have a data on transpulmonary pressure during the non-invasive ventilation, and so also some objection to the use of it may remain in part speculative. However, as soon as we have situations where we are treating patients with the RDS, we well know that the possibility of just failing, represented in this paper by the small black squares that are the rate of failure, as soon as you approach this patient with pneumonia or RDS, the failure rate is higher. And this is much higher in comparison to what you can get when these patients suffer from acute pulmonary edema. And Alexandre Moule beautifully showed how, as soon as you have a failure of non-invasive ventilation, and also in patients with immunosuppression and a higher severity rate, the possibility and the risk that they may get to die is much higher. And another concept which is implicit on the application of this technique, also if this specific study does not refer to immunohematological patients, is the idea that as soon as you just insist in delivering this technique, postponing an eventual needed intubation, you may be harmful for your patient. And in this study coming from the Tony Torres group, what has been demonstrated that as soon as you have a longer period of application and you postpone the mechanical ventilation given invasively, the risk of inducing a higher mortality rate is higher. We know from the study of Gilles Hibert that the patient, this is the original study published many years ago, that these patients may have a major benefit, even though in the group of hematological patients in this study was only in part represented, but it may have a major benefit in terms of reduction of complications. I'm referring to the infectious complication, namely. And also in another survey, which was a multinational survey, again with a small group of immunosuppressed patients, the number of those who avoided the endotracheal intubation being treated with non-invasive ventilation was quite higher. Here in France, there were other studies that consistently always show that as soon as you had a successful application of non-invasive ventilation, the hospital deaths, the hospital mortality, as well as the one that you can get in the ICU, is quite low. But, on the other hand, also in these patients, as soon as you fail non-invasive ventilation, the possibility that you're going to die is much higher. And again, the same signal was given when you analyze different modalities of ventilation. However, in this specific study, the association with a specific technique to deliver non-invasive ventilation didn't show any major difference. Interestingly, in the large survey that we have done in Italy on hematological patients more than 1,300 patients. Again, we could demonstrate that the successful application reduced the mortality, and indeed the non-invasive ventilation was a protective tool to reduce the mortality in these patients. But at the same time, the risk of developing or having an RDS represented a major risk for dying. And then you always have to approach also these patients with a lot of concern. If this is true, it's also true that the context changed over time. It has been beautifully shown by Elia Azoulay and his group, demonstrated that the changes of the therapies, the evolution of the concept treating these patients produced very good effect, because it was capable over the years to reduce importantly the mortality. And the number of the patient who received, under this condition, the administration of non-invasive ventilation went up over the years. And the mortality rate was reduced, hospital mortality rate, from 75% up to 40%. So there are complex congeries of interventions that may just, in a way or another, determine a different evolution of these patients. Always the Elia Azoulay group showed an interesting application of the new definition of RDS in hematological patients, demonstrating that the different classifications were indeed very consistent with the expected mortality rate in the different categories of severity of these hematological patients. And interestingly, also the application of the non-invasive ventilation was indeed more and more. But one of the concepts that, in my opinion, may represent a fundamental message is that also those patients who were ventilated invasively had a reduction of the mortality rate over the years, which means that despite the fact that we were feared in the past of the infectious complications induced by the invasive ventilation, nonetheless, the progress of our intervention lead to an improvement of the mortality also for those patients who are intubated. So, in my opinion, as soon as we identify criteria for intubate this patient, we shouldn't hesitate to do that. These criteria, however, are not so simple. And if we compare the criteria that we apply for intubating these patients to those that we applied in immunocompetent patients, you see that they are not very different, and to some extent are not so straight, because you may have not an improvement of PaO2, FeO2 after the application of non-invasive ventilation, let's say 1 hour of application, or you may have the hemodynamic instability. But indeed, apart from some magic number coming from the different studies, the suggestion criteria are more wise and logic criteria than supported by strong evidence. A new different approach, which can be very important and to some extent may represent also an alternative, is represented by the high-flow oxygen therapy that has several potential advantages illustrated synthetically in this list of benefits. Consider that in addition to that, the proportional increase of the flow delivered to your patients has also, as a consequence, an increase of a small effect, increasing the positive N expiratory pressure in these patients due to a expiratory brake effect. And this is made beneficial because can deliver constantly a small amount of pressure that can avoid atelectasis and this ventilation. And in one of the previous studies on this issue, not in hematological patient, we could demonstrate that in a randomized study in post-operative patients that there was several advantages, mostly in the ameliorating the PaO2, FeO2, and the respiratory rate and oxygen saturation over time, but also a reduction of the number of patients that could have been intubated subsequently or receiving non-invasive ventilation compared to the normal oxygen therapy. Then came the French study, the Jean-Pierre Frat study and his group, published in New England Journal of Medicine, where there was a comparison of 3 different arms, one with high-flow oxygen therapy, the other one with a standard oxygen group, and the third with, in non-invasive ventilation. All patients were quite homogeneous at the baseline, and at the end, there was no major difference. However, you can see that the immunocompromised patients that were enrolled in this study represented a minority, no more than 4 or 9%. You know the final results represented in picture by these graphs, where the cumulative incidence of intubation was not different in 3 different categories of patients. And for those who were in a more severe conditions, indeed, the more advantageous way to approach this patient was the high-flow oxygen therapy in comparison to non-invasive ventilation. I personally have some concern concerning the final results of this study, not because it's not very well conducted, but because, for instance, there were some problems concerning the application of non-invasive ventilation. I think that we have the Alps that divides 2 different mentality approaching non-invasive ventilation. The Italian way that says you have hypoxic patient, you should go on continuously for several hours in order to give to the patient a continuous level of pressure into the airways, which is the major determinant of the PaO2. And the French way, they say you can give it intermittently. Well, indeed, there is no final answer to that. And the specific study is also a crossover. And large part of the difference mortality that has been shown in this study were related to the onset of circulatory shock that, to be honest, has not much to do with the way in which you ventilate these patients. More specifically, the group coordinated again by Elia Zoulet presented a new study published in the JAMA regarding the application of non-invasive ventilation versus the high-flow oxygen therapy in immunocompromised patients. The number of patients were quite well represented, and most of these patients, something like 10%, had indeed severe conditions such as RDS or something similar to RDS that can be represented by the invasive pulmonary aspergillosis. And in these patients, the primary and secondary endpoints represented by the number of intubations and the all 28 days mortality was not different. And this study tells us that if probably the high-flow oxygen therapy is an optimal mean to approach these patients, indeed also non-invasive ventilation does not harm. But again, in this specific situation, this lack of difference, in my opinion, was in large part also attributable to the way in which is delivered the non-invasive ventilation. These patients receive in total each day something like 6 hours, but often the continuous application did not exceed a couple of hours with long period of interruption and supplemental oxygen. And this is my point. One of the major determinants of the ventilator lung injury is indeed the recruitment and de-recruitment phenomenon, which changes the pattern of the alveoli and gives an ignition to the inflammatory cascade, provoking the damage of the lung that is induced by mechanical ventilation. What happens if you give in this severe patient, most of them having already a mild RDS in the early phases, if you give non-invasive ventilation intermittently, that you recruit, you have a stable pressure, and as soon as you disconnect them, and for instance, you apply after a couple of hours the conventional oxygen therapy, you de-recruit. And this recruitment and de-recruit mechanism can be one of the reasons why the non-invasive ventilation is not so beneficial, and indeed is not a real improvement in comparison to the high flow oxygen therapy.
Obviously, this is a logical reasonement. I don't have any proof of this concept, and we need some obvious studies focused on that. But whatever would be the definitive conclusion, and the patient should be intubated, then you have to titrate and you have set up your ventilator. And the only suggestion that I can give you that whatever would be a mild RDS or moderate RDS, the principles are the same. The classical 7, let's say 8 ml per kilogram ideal body weight. The level of PIT should be titrated looking at tables or different tools, and indeed the FiO2 according to the tables. So my conclusions are that in immunocompromised patients with mild or moderate RDS, the early non-invasive ventilation, whatever would be the system, CPAP or pressure support, can be used as well as the higher flow oxygen therapy. Obviously, if you have a failure of non-invasive ventilation, the mortality is high, and if it is needed, the endotracheal intubation, again, no hesitation to go on, and the outcome improved also after that you have ventilated invasively these patients. Thank you for your attention.